everybody. We welcome you all to the potpourri session of the day. This has several talks. To begin with, we would uh, have a keynote address by Professor Amod Gupta. Professor Amod Gupta is not present here physically. He will be giving a virtual presentation, which is in a pre-recorded format. Can you please play the presentation now?
Thank you very much, Professor Suresh Gupta, for inviting me to speak to the young attendees this morning. I'd like to share some of my experiences of what I didn't learn by living alone, and some of these things might be useful to you in your lifetime. I'd like to share the story of a 10-year-old boy who was referred to us nearly 45 years ago, and I happened to examine. I was just 27 years old at the time. I was highly arrogant. My head was swollen with freshly minted knowledge. I'm sure all of you would have that swollen head on your shoulders, sooner or later. And one look at the fundus of this patient. I'm not asking what the challenge here is. I'm sure you all know. And I declared, loud and clear, the father who accompanies this young child, your child has blood cancer. And as soon as I uttered the words, I heard a loud thud. His father had been standing, fell down with the thud on the ground, on the floor, broke his neck, profusely bleeding. I had to virtually lift him onto a trolley and rush him to the emergency to save the life of this man. What's the moral of the story? Despite having all the knowledge and the skills that any 27-year-old young ophthalmologist will have, I did not know how to communicate with the father, the parent of the child who had a life-threatening disease. Nobody had prepared me, nobody had taught me how to communicate these decisions. How do I break news? When you encounter a patient of glaucoma, or a patient with retinal detachment, or a wet age-related macular degeneration, or endophthalmitis, put yourself in the shoes of the patient, the parent. This news that you have glaucoma and that you are likely to go blind is stunning, to say the least. Is life-altering. The moment you utter the words, you have this. The patient or the parent, they stop hearing what you're saying. He's calculating in his mind, how long do I have before I go blind? The kind of treatment you're prescribing, how do I manage the finances? Or who's going to put the drops in my eyes? Have you given it a thought? If you are in the position of sitting in the chair of the patient rather than the physician, it's shocking to say the least. How do you break that news? This is the skill which is not taught to us ever. We learn it, we imbibe it by looking at our teachers, by looking at our seniors. And it's your great luck what kind of a senior or a teacher or a professor you have. I've had teachers who would be abusing, all kind of NCs and BCs to the students and to the patients. Probably I might have behaved in the same way at some point of my life. How you communicate is the key. Patient is not interested what you're looking at the computer, what the data you're filing in the computer, in the patient charts. Look straight into the eyes of the patient, make eye contact. Talk to the patient. look interested in what the patient has to say. Feel empathy, feel pain of the patient when you are breaking such a news. I'll share another example of this young man. He was the editor of a news weekly from Chandigarh. He was a diabetic, and nobody had told him till that time that this person had diabetic retinopathy so advanced that he had extensive bilateral, extensive fractional retinal detachment. He was still seeing something. He was still seeing. He never had any laser photocoagulation. Now he comes to me and I tell him, look, this is what you have. You have normal vision. What I'm going to do, and those were early days, almost, I think about 15, 16 years ago. Yeah, I'm going to give you an injection of Western anti-VEGF because you have extensive, huge proliferation of these new vessels in your retina. I'm going to, shrink these vessels before I do the personal vitreous surgery to put back the retina in place. I gave the injection. This person at this point of time is 6-9 vision. What do you have? He comes to me 2 days later. He's lost that vision. He had a fractional detachment now, which has become a combined retinal detachment, either vitreous hemorrhage. Things have gone from bad to worse. I never prepared this patient. Luckily for him, I could manage to fix his retina and he recovered 6/6 vision eventually in both the eyes. But patient comes to you with certain expectation, and if you don't ask the patient, what do you expect from me as a physician to be able to do for him? When you're dealing with situations which are life-altering situations, you need to address these situations right in the beginning when you undertake the care of these patients. Like I'll tell you the story of another patient. Now this is a guy who had been around the country. He had gone to all the major centers. He had lost one eye. With a diabetic, he had lost one eye because of vitreous surgery, which was, kind of bad surgery. He had no light perception. The only other eye, he had hand motion vision. He came with the help of his younger brother, and he put his hand on his shoulder, and he was led into my clinic. Just hand motion vision. I looked at him and I said, look, you have a very, very bad case of retractional detachment. His macula was lying in the middle of the vitreous cavity. Everywhere he went, they had added more and more laser coagulation with retina. But nobody he had been admitted at least twice to various centers, but nobody touched his eye. They had touched his eye because they knew that this patient will become blind. But that's what he had, the bad outcome with the other eye. Well, I said, I'm going to undertake the surgery. He said, we have come as the last hope, otherwise he is blind for all his life, and he's, just early 40s. I said, I'm going to do this surgery. And sure enough, I'll do it. I'll not run away from this field, but I can't assure you of the outcome. He said, no, you give your best, and whatever is our, fate, whatever is written in our future will happen. I said, fine, fair enough. We spent a few hours doing the surgery, and he had good outcome, fortunately for me. The patient came back for follow-up a few months later. He walked on his own. His personality had changed. He was looking much confident. And I told him, look, you're looking so good. And he read the line 636 from hand motion vision. He was walking independently on his own. And what does he tell me? He says, Doctor, but I can't read the newspaper. Oh my God, I never realized. I never asked him What is it you want in life? Do you want an ambulatory vision or do you want a reading vision? I would have told him there and then, right in the beginning, before operating, that you are not going to get a reading vision ever. This is around the time that I retired a couple of months later, in 2015. And this patient, the brother happened to be a big-time correspondent of a major newspaper of India and come from Lucknow. And I got worried, and for good reason. This fellow is not satisfied. I have not been able to match his expectations with my outcome. Although in my own mind I was congratulating myself and I dare congratulate the patient that took the road for vision. As much as was possible in the ischemic retina. And a year later, the day, I get a call and I got scared. I'd saved his number. I knew this guy is calling from Lucknow. Oh my God, what's going to happen to me? And he told me, Doctor, I thought I'll let you know. It's exactly 1 year that you operated my brother. That today, this morning, he read newspaper. Oh my God, I said, thank God for saving me. A miscommunication between what you can deliver and what patient expects. This is what it looks like. And nobody would believe that this fellow would be able to read newspaper when he came on the day presented to me. So, when you're talking with the patient, I think you should be looking at it. Don't use medical jargon. Talk to the patient, explain to the patient in his own language what he understands. You can take the advantage of using the computer screen for explaining to the attendant if the patient can't see. Encourage him to ask, what are you expecting? What do you want? Okay, mind your body language. I'm sure you are all busy in the clinic, you're surrounded with patients. Don't show impatience. Talk to him when you're alone. Don't let other people crowd. Don't look distracted that you have a big crowd waiting outside, so hurry up. No, don't show your hurry. Make frequent eye contact. Talk to him, looking directly into his face. And then discuss with him when you're undertaking, especially some of these procedures. Address your patient by first name. You might think, you have the report right there. He's a Rakesh Gupta. If you call him Rakesh, how are you doing? It's a very big deal. I tell you, patients have told me so. They say, Doctor, you're so busy, you remember my name? Oh my God. They become your followers. They will remember you forever. They will become friendly. They will not mind waiting for you because they know. Always give appointment to the patient. Don't leave it, come after 2 weeks, come after 3 months. No, give a precise date and time. If they miss that appointment, write a letter. Write an email. I have had the fortune of getting almost 95% follow-up rates. Nobody can claim that in this country ever. How? Because writing emails and writing mails and letters, I used to write physical letters. The reason you have missed, the patients appreciate. This, oh my God, the doctor is concerned about my welfare. He's concerned about my doing. That is what the kind of relationship you need to develop with your patients. Moving on, I'd like to share the tale of these 3 physicians who, in a long time back, they trained under a guru in an ashram, like they used to do. And once they have completed their training, the guru told them, go and visit the king, he will reward you. So these 3 friends, they started walking to the king's palace. On the way, they met a friend who never went to any ashram, he was illiterate, and he said, you are going to the king, why don't you take me along? They said, this foolish man, illiterate, he is going to bring down the street when we present ourselves to the king. So he insisted that, you are my childhood friend, why don't you take me along? No, well, they took him reluctantly, they agreed and took him along. When they were coursing through a forest, they came across a heap of bones. I'm not sure how you read this Panchatantra. But one of the friends who had trained him in anatomist, he had one look at the pile of bones and he says, I'm sure these are the bones of a lion. And I have the skill and knowledge how to put together this bones into a skeleton. And he went on to it. Sure enough, it looked like the skeleton of a lion. And he looked vaguely at his friend and said, look, this is what I told you, that this is the skeleton of a lion. At this, the other friend, one of the other friends, he got agitated. He had trained to be a plastic surgeon, and he said, look, I have the skill and knowledge to fill this skeleton with flesh, muscles, and skin. I can do it. And sure enough, he put all that together, and now it looks like a lion. Looking at that, the third friend, who had trained to be an anesthetist, he was feeling let down. He said, these guys have shown their skill, let me also show my skill. And he says, look, I can put life into this. Hearing this, the illiterate friend said, my God, lions are known to eat people. Don't do it. The anesthetist would have none of it. Hearing that he would have none of it, the illiterate friend climbed up the tree. The lion came to life and ate up all the three friends. With all the knowledge and skills, I didn't know the context of applying the knowledge. What's the moral of the story? You may have the knowledge, you may have the skills, but it has to be contextual, appropriate time. Application of that knowledge is more critical than the knowledge itself. And that is why you need to go to school, you need to go to medical school, you need to have teachers, you need to have professors who know how to apply knowledge because they burn their fingers during their lifetime. They know what is the context, how to apply that knowledge. You as students are yet to learn that, yet to have that experience, yet to gain that wisdom of application of knowledge. The mere possession of theoretical knowledge of skills is not good enough. And this is not today, even long time back, Heraclitus, if we come to in a little while later, even 2,500 years ago, he felt that people had a lot of knowledge. They were foolish, they were senseless. Just imagine, if the knowledge we possess is incomplete and not current, story life. I'll just give you a simple example, like that these are the patients of fibrinous anti-uveitis, acute uveitis. This is an example of a hypopion, mobile hypopion. This is what fundus looks like in the patient disease. These are the well-known indications of corticosteroid. And if you have the knowledge, you have the skill of applying and writing the prescription, you do that. But one of my friends, close friend, in fact, he saw this hypopion and he saw this fibrin 6 weeks after small incision touching surgery. Since he had incomplete knowledge, he did not know the context of application, he put this patient on corticosteroids. Because he had heard that corticosteroids are given for inflammation. What you have is a frank conjunctivitis due to a fungal infection in this patient. The context is all wrong. For this patient, the ophthalmologist had the skills, he had the equipment to document this patient who had necrotizing retinitis sitting next to a retinal scar. This patient he treated with oral corticosteroids, with stereosubtin 1 he kept on treating these patients 9 months. A patient came to him at 6 vision, and he would quit treating this patient, refer to me. 9 months when the patient had gone completely blind, and this young girl felt so sad. This patient was treated on corticosteroids for a necrotizing retinitis for toxoplasma retinitis. The person had the knowledge of applying corticosteroids but didn't know the context. What context? The child was being blind. So which is a bigger sin? Not to have knowledge or apply it wrongly? This is what you have to think, what you have to do. Now, you have had knowledge so far when you are doing your graduation, foundation course. In a way, even the postgraduate course, the MS, is a foundation course. It lays the foundation of basic knowledge and basic skills. But once you qualify, once you are a postgraduate, a specialist, whatever you learn, you have to learn it forever. Nobody will come to hold your hand or guide you when you are sitting alone here in a clinic and don't know what to do with a patient. So you need to know how to learn forever. I'll give you a little bit of my own algorithm about the physiology of learning. Patient is a stimulus. Now, if this stimulus or if this patient is able to arouse your curiosity, you just know what this patient has, what his pathology is, what is he having, and you get an answer, with or without the help of your speeches, with or without the help of literature or books. You get an answer. You are rewarded. The curiosity, if it is satisfied, is rewarded by release of dopamine in your brain. And this is the reward system in your brain which makes the memory. Of course, you need to repeat it after an interval of 4 weeks again, and this memory becomes permanent memory. You will know it forever. So if you have wrongly treated a patient of toxoplasma retinitis, corticosteroids, burnt your finger, and somebody told you that you don't treat a toxoplasma retinitis with corticosteroids but give anti-toxoplasma treatment, beforehand, before 48 hours, before putting on steroids, you would have learned that lesson forever again. You will be absolutely foolish if you repeat that mistake. Now, what is the physiology of boredom? When you're sitting in the classroom, when you're listening to the lecture, you're reading a book, you're reading again and again, there is repeated stimulus. There's no curiosity. If there's no curiosity when you're looking, you're navigating the day, you're looking at the crowd of patients sitting outside, no patient is aroused in curiosity. It's not stimulated your brain to be curious what this fellow has. If there's no curiosity, whatever the answer you get, it does not reward. There's no reward. The reward has to come following your curiosity. The dopamine has to be released. But what happens sitting in the clinic when you're repeatedly seeing the same patient, same kind of stuff in everyday life? There's no reward system here in play, and you may have the answer, but it leads to boredom. Once there is a boredom in your learning, and I'm sure you will go back home and realize that you keep reading the book without knowing what you just read. That's what is boredom. You're reading, but you don't know what you're reading, what you learn. Okay, so remember this as a fact of basic facts of learning. So always learning context. So when you see a patient in the clinic, you go back. That's the day, because the patient is still fresh in your mind. Go back and look up their textbooks, look up the literature, ask the patients, discuss with your friend, this is what I saw, and that experience will remain in your memory forever. So I have emphasized enough that you must be curious. If somebody comes and tells, okay, this is a patient of BKH, and you didn't show any curiosity on your own, but your teacher comes and tells the patient you are seeing is a patient of corneal ulcer, or uveitis, whatever it is, and it's not come out of your own curiosity, urge to know what it is, you lost it. there will be no memory formed. You will not have done anything. So when you are seeing, or when you are hearing a lecture, or when you are seeing a patient, you must keep on asking these questions. Okay, what does he have? Where does he have? Why does? How long? You know, you can frame hundreds of questions relating to a patient sitting in front of you, and it doesn't have to spend half an hour to ask those questions. This can be very, very quick process of asking. It's a question of whether they have it. You know, very simple. These days, life is very simple. It was much tougher in our days. Google knows all the answers, but we don't know what to ask it. If you ask a vague question, it will come up with a million answers. You don't know, you'll get more lost. So you have to be very, very specific. If you are very specific in your queries, and you ask Google the questions, very specific, it will give you very specific answers. That is how you are able to generate research questions that do not have the answers. So before you start learning by rote the answers, learn to frame questions. I mean, that's the key message I'm making. Learn to ask questions, frame questions around a problem that you see. Learn to observe, learn to see, learn to see what the patient has, learn to, like I'll give you an example. There's a very famous painting by Raphael in Rome, in the Pope's library. Right? Shows this is called School of Faith. It's all the philosophers, Greek philosophers are here. Plato here, Aristotle here, Heraclitus, which I mentioned. This is the Archimedes here, the Euclid here. You can see. So all these philosophers, big time, major discoveries in life, they're depicted in this painting. Millions of people have walked through this gallery, you know, with an excellent example of Renaissance art, which is shown in 3D, as you can see. Now, till Sarah Walker, you know, she was a physician, US physician. She was looking at that and she said, well, this is Heraclitus, philosopher I mentioned a while ago. Why his knees are swollen, knobbly? Why like this, bumpy, knobbly knees? Did he have gout? She had gout. Now, this was a time of Renaissance where they used to model, they used to exactly make a model, sit across and draw the likeness of that person, set like that. This period lasted for about 30 years or so, where they used to paint, and all those paintings are available in the museums across the world, major museums all over the world. So when you were looking at this Heraclitus and found this down, she said, I must look at Raphael couldn't have drawn this for Heraclitus. She didn't know that Heraclitus had gouty knee or arthritis of this kind. So she went and looked at all the paintings drawn, knees drawn by Raphael. And she didn't find anyone whom he had drawn knobbly. So she came to the conclusion that the model, the person who was modeling for this, was probably having a gouty knee. Looking at this painting, out of millions who have seen this painting, she reached this diagnosis of this model. And this here is. Now this is just example, another example of observation power. And here, what is depicted, and there are several paintings showing the same story of this young lady, Procris, who got shot by an arrow by her husband, Cephalus. This is a story, and this is a central mourning over the loss of this. Now, this is a painting which everybody has gone see till an oncologist comes, Michael Baum, by the name. He looks at this and he says, how come this lady has, this kind of claw here? Why does she have blood stain in her neck? Now, the story was that she was shot by an arrow. And here he comes to the conclusion that this patient has had injury to the spine. Somebody has hit this person with a chopper on his neck to cause a swelling of the neck at C3, C4. So this is the way to step by you injure the brachial plexus and you get that kind of injury. And he spotted that. He said, this is not the model. So the person who was fetched from the mortuary was probably a person who was modeled, the corpse was, the model had been murdered, by someone. So this is the power of observation, and there are any number of the paintings which give a clue to the possible pathology. Now, how is it applicable? It shows your sharp sense of observation, acute sense of observation, and it has been used in ophthalmology training. And a randomized trial has been done that if you expose the residents or the student to a museum, ask them to describe the painting in detail, the context and what is happening in that painting. Not have time to go on to, I will show several of the paintings where they use, like here, the paintings to describe. And they found that the residents or the students who had been exposed to the museum training of a few hours developed much sharper observation skills in ophthalmology. And it improved their clinical observational skills. Now, medicine is all about clinical observation skills. Irrespective of the fact that the modern day technology of scans and labs, has reduced it to a sham. So that's not the true physician will do. The true physician would like to observe the patient and then order the labs and the scans to reach a definitive diagnosis. So that's for another day. So learn to model. When I say model, I'm not asking you to model a fashion model. I'm asking you to describe what you see. I was fortunate when I was student of class 6 and 7. We used to have the modeling classes in that point. So our teacher would put up an object, on a stool and would ask us to sketch it, exactly describe. When I asked my residents, to look at a patient of fundus, the patient's fundus diaphragmopathy, and ask them to draw that, they would draw exactly the same picture as they had seen in the book. Because they carry that image from the textbook of diabetic macular or diaphragmopathy. They do not know how to describe, so every aspect, how does the disc look like, how the vessel look like, where are the vessels, where are the hemorrhages, where are the lipids, all that you need to develop. Unless you develop that skill of describing accurately what you're seeing, you will not really be modeling or observing, but developing sharp observational or acute skills. You can have a long discussion about how it helps you to describe, new diseases. I was fortunate to describe several diseases, before anybody else could do, by honing that observational skills, thanks to my drawing teacher who exposed me to model objects, describing great details about what they do. So in summary, what I have told you, some of the few cues have provided how you could learn communication skills, how you should learn how to apply knowledge, why you need to learn forever, because nobody is going to hold your hands. No professor is going to come to your rescue when you're sitting in a clinic. You have to deal with diagnosis and management of the patient all your life. You can do that by learning, by asking questions, by raising queries, so that you'll be able to exploit all the Googles and all those, such platforms that are available to you for the relevant literature available in the world. Learn to observe, learn to describe. If you are able, this is my last regret in life, that I could not hone my skills exactly to be able to describe in patient, break them into tiny descriptor. That one patient I see, I break him down into 20, 30, 40 descriptors and then see. When you see such a rare patients who have never been seen before or been seen only once or twice in the world, to come across those patients, this kind of a skill of descriptors, breaking down the patient into descriptor, will come very handy. Unfortunately, you don't get to see, read this, or get to learn from the textbooks. Thank you very much again, friends, for giving me this opportunity, and